Hi, Paul Sakis, Good News Planet. We're going to talk about health disparities in the U.S. exposed during COVID. Calls for less talk, more action. A new report in charting a bold roadmap to achieve health equality by 2040. We're talking to Dr. Keith Rawlings. Hi, how are you today?
I am very well. Thank you for having me.
Okay. Well, you're Senior Medical Director at Disparities Healthcare, and we're going to discuss some of these health equities, particularly in the groups of Black, Latino, and minority ethnic groups, and trying to eliminate these disparities. And there's, I guess, some new approaches to it, and as well as concerns over the HIV epidemic. So, thank you. So, tell us where we can go with these good thoughts here.
Well, I would start off by saying that health disparities are really preventable. They are an issue that we need to begin to think of as what are we going to not just talk about, but what are we going to do? And in many ways, those disparities have grown over time. This isn't new. This isn't just related to HIV. Our study looked at both substance abuse and mental health issues along with HIV and the impact that COVID had upon it. And we looked at it not just in the U.S., but in the United Kingdom. And what we discovered is that these are issues that impact all of us. This is not just a one population concern, but it is an impactful process that we have seen repeatedly exacerbated by COVID-19. They are avoidable, unfair differences that affect particular people and specific impact their quality of life and life expectancy. And unfortunately, that tends to concentrate into individual populations with low economic status, but also racial and ethnic minority groups, as well as sexual and gender minority groups. And I think that is the important take-home, that this is an issue that all of us have to confront.
And so, and how does that happen? And maybe you have an example.
Well, I'll look at it this way. The U.S. In healthcare disparities, particularly amongst Black and brown people in the United States, have contributed to almost $90 billion in excess medical costs and $42 billion a year, excuse me, in decreased productivity. And unfortunately, because these disparities are often self-perpetuating, for example, if the person is too sick to work and then they experience low income or unemployment, those individuals are less likely to have access to health insurance, and this makes it more likely that they will not seek preventative services or even treatment. And if we're going to address these problems, we have to recognize that this isn't just about the individual living with the problem or this disease. It is about what it means to our overall systems. COVID has shown this very clearly. If you have a heart attack and you need to get access to a bed in the hospital, you may not be able to do it, even though you have insurance, because it's just not available. And we need to begin to think about, on the long-term basis, how can we begin to address some of these concerns? As a clinician, I must say that, if we as just simply about people who are poor, but it's not true. If you live in rural America right now, you realize that whether it's COVID or substance abuse and treatment programs that you may need, those resources just aren't available because of the incentives for our healthcare systems and where we put those resources. And if we're going to address these things, we need to take into account that this is a societal problem. It does impact certain communities more than others, but it eventually impacts all of us.
Sure. That's fair. That's what would be. So what are some of the next steps that should be considered? More health care in certain areas of multicultural communities? Let's call them.
Well,
even though we all are multicultural.
Yes. Our report actually looked at various components of this. I mean, yes, it is a restructuring of our system to incentivize prevention. If we are going to address this. The current system still focus on the treating of people who are sick rather than preventing health illness. We need to make sure that the resources are where the problem is. If you are looking at substance abuse, for example, you need to make sure that not just that you put treatment programs in the communities that are being impacted, but also what does it mean when you concentrate all of these programs into certain neighborhoods? We need to think about those types of things and do long-term investment strategies while developing better measures of how we're going to decide if it's working. We look at investment in healthcare systems in individual communities over the long term, not just the short term, and look at whether or not that is actually changing the healthcare status of our communities. In some cases, that's about putting medical care there. In some cases, it's about putting a grocery store where people can actually get the appropriate foods that they need for their nutrition. And then make improvements in the way in which we talk to the people that we are working with. For a long time now, we have seen individuals can make a difference, but their impact is limited if we are not having a better fostering of understanding about equity and health inequality in the systems themselves. Practical changes that improve collaboration, like improvements in data sharing or more efficient referral processes, are easy but clearly often overlooked realities. And I think I would say is that we need to do a better job of how do we reach certain populations. HIV is a great example in which we have tried to, over and over again, narrow the conversation to particular demographic groups. But the impact of who can benefit from treatment, who can benefit from prevention of HIV, substance abuse, mental health, has shown that if we do not incorporate new practices from outside of just the healthcare sector in planning and organizational structure, we'll continue to perpetuate some of these same inequalities.
Okay, very, very interesting. Actually, my company's been doing multicultural marketing since 1985, and a lot of it, reaching out to the different communities, and it seems like more interest has occurred. Maybe that's on the consumer, maybe on the marketing side, but health is still wealth. Health is bottom line stuff. It sounds like you're really focused in on keeping the multicultural community safe.
Yes. And the last part that I would point out to people is that it's not only important to talk about these things, but it's also important to make sure that the messengers are reflective of the population and the communities that you want to reach. That you're also making sure that the research or the development of interventions and studies reflect the demographics of the people who are living with the problem. And if we are able to begin to do this, we can begin to hopefully have an impact not only on the individual and on the community, but societally. I mean, billions of dollars every year are being spent on healthcare disparities alone, or inefficiencies, or the loss of productivity. And I think that we really need to, as a country, begin to pay more attention to this. And to be fair, it is not just in the U.S. This was also found in our analysis in the U.K., these same kinds of issues.
A lot of wisdom in these comments and a lot of reality. I've been being in this marketplace for a long, long time. Do we have a website that we can send some people to?
Yes. I recommend that you go to VIIV, healthcare.com/health equity report and to see some of the recommendations for both individuals as well as systems that we may be able to do over the next few years.
Dr. Rawlings, thank you so much for sharing.
And thank you for having me on this, I think, very important issue. And I wish everyone a very happy holiday season.
Same to you and everyone around you.